Welcome to our presentation by Brianna Prescott and Lauren Weaver. This presentation will focus on a patient that was assigned during the week of July 26th at Mercy Claremont on their behavioral health unit.
The patient is a 50-year-old female diagnosed with bipolar I disorder. She also has diagnoses of ADHD, depression, and alcohol withdrawal syndrome with delirium. She has a medical history of genital herpes and pneumonia. She had a cholecystectomy in 1988. According to her social history, she was a former smoker and she used to drink 56 cans of beer per week.
56 cans of beer, that's eight beers a day.
Yeah.
Just the breakdown there.
And Lauren knows her history a little bit better as far as her family history.
The patient, just social history as well. She's 7.5 pack year smoker. She reported smoking for 15 years, about a half a pack of cigarettes a day. She has since quit. She reports that both of her parents are still alive. Her uncle, that's her father's brother, is diagnosed bipolar disorder, and the patient reported that she believes that her father could also be diagnosed as bipolar. However, he is not one to seek out help from a psychiatrist or really medical help in general. That kind of covers everything there. The patient reports a history of abuse. She reports that both of her parents were physically and mentally abusive as she was growing up. She has 5 other brothers and sisters that she reports also sustained abuse growing up, and she has a relationship still with her parents. However, she reports that it's strained. She doesn't talk with her father much. She does still speak with her mother, but that relationship is strained, and she says that her mother still is somewhat psychologically abusive, and the patient's relationship with her mother, yes, is quite strained from what I've gathered. So as far as objective data goes with the patient, her physical exam showed mostly within the defined limits for most physical assessments. She was visibly congested due to seasonal allergies and was awaiting a prescription for Flonase to relieve some of that congestion. She reported bilateral pain of the finger joints, and just a minor swelling was visible in those finger joints. So just consistent with osteoarthritis, which is not particularly unusual for someone of 50 years old. She reported being on her period and also has a history of genital herpes. Her CBC showed values that were within the normal ranges, and urinalysis as well was negative for any bacteria, and everything was within normal ranges. The patient, there were no diagnostic tests really on file, but she reported her last gynecological exam and mammogram were within the last year. And there were no vaccinations on file. The patient believes that she was up to date on vaccinations. She reported not having a yearly flu vaccine, but she believes she's up to date, but was not particularly knowledgeable as to when her last vaccines were.
Okay, according to the DSM-5, this would be how you would diagnose somebody with bipolar I disorder. You have to meet certain criteria to be diagnosed with this. in observing the patient, she meets much of this criteria. She was very talkative. She was a little bit of pressured speaking, not all the time, but she did have it. Flight of ideas, I would say.
Very, very outgoing. I think any of the students on the unit would have recognized this
Absolutely.
patient. She introduced herself before we were even able to introduce ourselves in the
Yes.
morning. Very, very outgoing, very social, very open, and willing to share
Everything.
tidbits about herself. Yes. Bit of an oversharer.
But I would, yes. I don't know if it would be distractibility. She's not so much distracted, but was very.
I think distractibility that would go somewhat with it.
A little bit.
I mean, that would go with her diagnosis
True.
really of ADHD as well.
That's true. Very true. She was very goal directed when it came to group therapy, and then you can
Very
speak more
much so.
to how.
She was also hadn't slept much the night before, or at least reported having not slept a whole lot, which goes along with a bipolar kind of manic phase. But also with the goal direction, she had been up all night or early in the morning. She was writing goals on that whiteboard that's kept in the patient's room, where they write their daily goal. But she had, I would say, a minimum of 6 goals written for the day. She would pray excessively for an extensive amount of time. Very hyper-religious,
yes.
and very concentrated on the prayer. She prayed with her head down
during the fire alarm.
During a code red drill.
Correct.
That lasted 20 minutes or so.
Praying for everyone's safety.
Yes.
It was very extensive.
Yes. So yes, the goal, very hyper goal directed, I would say.
Absolutely.
Yeah.
The pathophysiology of bipolar 1 is not completely understood. There's differences in brain structures. There's an alteration in the dorsolateral prefrontal cortex and amygdala that has been discovered. There's also been an increased response of the amygdala to emotional cues. PET scans show an increase in temporal lobe activity and amygdala volume. It is also believed that there may be a strong genetic predisposition to this. They may be linked to gene codes for an enzyme called diacylglycerol kinase. I could be saying that improperly, and I apologize for that. It's part of a lithium-sensitive pathway. Chromosomes 13 and 15 are known to carry genes for bipolar disorder.
Yeah, which is unsurprising. That goes with the patient having a family history of bipolar disorder. Known in her uncle and suspected in her father. At least she self-reports a suspicion of family history in her father as well.
All right. The patient is currently taking risperidone for her manic bipolar. She's on 0.5 milligrams during the day and 2 milligrams at night. Risperidone blocks dopamine and 5-HT2 receptors in the brain, and that's how it helps stabilize the mood in manic bipolars. It's also used in schizophrenia, I believe, for the same purpose.
Yes.
If a patient is taking this, you need to monitor them closely for signs for neuroleptic malignant syndrome. There's suicide risk. They're going to experience maybe a weight gain, hyperglycemia, tardive dyskinesia. I know is associated with that as well. So that would be something you'd want to keep an eye out for.
Yeah, the risperidone, she's really on it for its mood stabilizing properties to kind of prevent the highs from being extremely high, and then the next medication is to help with
the lows.
Yes, exactly.
Yeah, so the Zoloft that she's on 100 milligrams a day. It's an SSRI. So, like Lauren said, it's going to help with her lows that she's experiencing, and she also has a history of depression outside of just the manic diagnosis.
Yes,
so that's got to help with that too. Again, important to remember to be these patients should be monitored for suicide risk, just because although you may be correcting the depression, you are not correcting the suicidal thoughts associated with the depression. So these patients are at higher risk for that. And then weight gain is also associated with this as well. So you need to keep an eye out for that. Because the patient is a recovering alcohol, is she recovering completely at this point, or she's just,
Well, she's
because she hasn't drank,
she
so,
hasn't drank at this point. She hadn't had a drink for at least 3 days, and she is very vocal about
okay,
her
that's where my train of
willingness
thought is
and
then, yes, okay.
and wanting to yes, detox from alcohol and be on the path to recovery.
Okay, so that's what she's on vitamin B1 then, because she needs to replenish her thiamine.
Yes.
Because often in alcoholics, that is the vitamin that is deficient. So we want to replenish that.
So as far as plan of action moving forward with this patient, obviously one of the major goals is going to be, you know, with the treatment, it's going to center around the treatment. You want, of course, the patient to adhere to the medication regimen, whether it's the one that she is currently on or after discharge. You know, her psychiatrist, excuse me, decides that she, you know, that there might be something that's better suited for her. But medications is going to really help her being a, you know, bipolar patient,
from more manageable. She
yeah,
can manage her disorder
yeah,
more.
prevent those manic highs and prevent the depressive lows. Kind of keep her at, you know, that middle ground that is healthy, really, and just continued outpatient care to help with medication regimen.
It's important that she just keeps up with her her doctor and her medication, obviously, because if she isn't going there, there's just no guarantee that she is improving or staying the same. So it's just beneficial that she continues in her outpatient care. Yeah,
and it's very likely that she will continue to work on dealing with those past traumas of, you know, the abuse, the physical and emotional abuse she sustained as a child, and the sexual abuse that she reported having experienced in the past, helping to deal with those and learn to cope, learning better coping mechanisms with those that don't involve alcohol. And then, of course, she also will be seeking treatment for her alcoholism. So one of the main nursing diagnoses that we decided was best for this patient was readiness for enhanced knowledge related to desire to improve overall health, as evidenced by the patient's expressed interest in treatment for alcoholism. And we felt that an appropriate goal for this patient would be that she will explain the plan to incorporate treatment for alcoholism into her lifestyle by the end of her inpatient stay. She already is expressing a deep desire to change, exactly, and to willingness and wanting to access resources for her alcoholism. Once she leaves there, she expresses without even being prompted that she wants to change, she wants to get better. She had been given an ultimatum by her fiance that she needed help, and she had been denying it for a long time, and then eventually he was the one who prompted her to enter into the inpatient stay. So to contribute towards that goal, some interventions.
She's a perfect teaching candidate.
Yeah, she really is.
She really wants to change. She will be probably more easily able to accept teachable moments in her care.
I would completely agree. Yes, she has a expressed readiness for enhanced knowledge,
which is wonderful and huge. And that way, I think, you know, everyone could use individualized approaches that focus on her priorities and her preferences that she has expressed. And then we could, part of her teaching would come into helping her locate an appropriate resources for getting information, finding support, finding facilities that would be best fit for her and her treatment.
Yes. Likely that would involve helping her to locate her nearest chapter of Alcoholics Anonymous, finding out when they meet, where they meet, connecting her
with a
possibly,
sponsor,
yeah, with
maybe.
someone,
Yeah.
there who can really help facilitate her continued recovery with alcohol. So a second nursing diagnosis that we felt was also appropriate for this patient was ineffective coping related to mental illness as evidenced by alcohol abuse and hyperreligiosity, which
It was very evident.
yeah, so the hyperreligiosity was extremely evident, as we had talked about earlier. She became preoccupied during the day at times with praying. It was very ritualistic. It was
it was excessive.
Yes, she even it had been interfering with her life enough that a good friend of hers, had reported that they were afraid that, with her talking to God, if she believed that God told her to kill herself, that she would. There wasn't fear that she was suicidal, but that she was just following that she might follow commands if she believed that they were coming from God, even if they involved self-harm. So we felt that an appropriate goal for this patient would be that she would demonstrate and explain effective coping mechanisms by the end of her inpatient stay. Both the hyperreligiosity and the alcohol abuse are ineffective coping mechanisms. That's not to say that using religion in recovery is not appropriate. It just, hers became
excessive.
Excessive and interfering
affecting
in
her life. Yeah,
exactly. Absolutely. Which is, when you need to.
She just needs to recognize that and to find other coping mechanisms, because she has clearly she's been trying to, and these ones have been ineffective. So for her nursing interventions, we felt it was important to collaborate with the patient to identify her strengths and concerns and fears, to set some goals, and to recognize the main source of her stressors. Because if you recognize what causes you stress, you're already at an advantage to try and deal with it before it gets to an unmanageable level. We also thought it was important to work with the patient to identify previous coping mechanisms that she has used and see if she could describe the difference between the ones that worked for her and the ones that didn't, and why that was. Because clearly she has a history of alcohol abuse, which is not an effective coping mechanism, and she is clearly recognizing that because she wants to make a change for the better. And that is obviously very important, and it's wonderful that she recognizes that.
Right.
And then the last one we came up with was to aid the patient in identifying coping mechanisms that will be used in the future in times of stress. So yoga, exercise, meditation.
Possibly even a way to allow her to practice her religion, which she feels very strongly about, but in a more controlled, manageable manner.
Right. Something that doesn't take over her life, but is still a very big part of her life at the same time.
So possibly just kind of setting some limits on that.
Yeah. And that was our presentation, and these are our references. I hope you enjoyed it.
Thank you.